Over the next few years, you are likely to come across many people who have mysterious illnesses. And it may sound pretty much like an interesting story until it happens to you or a loved one. And so, what I'm sharing with you now is purely scientific and theoretical. But if you get the insights from this, this could be a lifesaver for you or someone close to you. So, what I'm sharing is about this case. Someone had sent me the link in the past few days, so I looked at it because I like to look at the details here. And this is from New Zealand in Stuff Don't Leave Us, hundreds of clots, failing organs, and no diagnosis. This is the bit that is really, really important because when you have this kind of picture, if there is no framework to work within, especially for the medical team, you are then grasping at straws, and the outcomes often are very poor. So, I want you to grasp what I'm saying. You don't have to understand the science, but you may need to advocate and push the medical team to think outside the box. In this case, if the relatives are listening in New Zealand, that's what I'd advocate for them to do, to really push the medical team to think outside the box. Because everything about this fits within the framework of what I call a COVID storm. And this is what it would look like. It's an iceberg, really. People will see mild symptoms initially, but the immune system goes into overdrive and causes a bunch of unusual patterns: fatigue, hypertension, stroke, heart attack, brain fog, memory issues, breathing problems. All of this kicks in sometimes weeks after what appears to be a non specific infection. So, let me take you through this case and show you why I think this is an example. So, let's look at this. As I said, this was on January 9th, 2026. And this is a fight for his life, the father's life. There are no answers yet for what is killing Ruben Fisher. Only the slow loss of breath, a failing heart, and a family trying to hold on. And it suggests to me that they are looking for help and support. So the initial bit is the story, and the link is in the description if you want to read it. The story about who this person is and what it means to them as a family. And you can see, because upstairs, the smiling man in the drawing is lying in bed, struggling to breathe, struggling to stay alive. And at the moment, he needs a heart transplant. But doctors are in the dark as to what has caused his catastrophic decline. Now, it's important to note that whenever I understand that, because everybody knows COVID as severe COVID, respiratory compromise, relatively fast onset, microclots in the lungs, and so on. But if you don't understand the subtleties of the science as to why that happened in the first place and what disease presentation will be in the future, it won't make much sense. So here is what happens in the real world, and you have to look for it to see it. So this is the case here. It's a shocking transformation. Just 4 months ago, 50-year-old, he was in good health, went to the gym twice a day, and competed in judo. Mid September, his wife came home from work to find him extremely sick. Okay. Now, the problem with this presentation is that it may be thought that his disease started at the time when he was sick. And this is where I said you have to understand the broad complexity of what is going on to be able to make sense of what this is. He was lying in a fetal position on his bed. He was incoherent, means he was confused, after he had vomited almost a liter of blood. Now, Clinically, this sounds like somebody who has what we call an upper gastrointestinal bleed. He's bleeding from his stomach or duodenum. He's vomiting a lot. He's incoherent because he's lost so much blood. Now, he was critically ill, and and this is the point here. So he will come into hospital with this being the history. And very quickly, what happens is that that becomes the focus of attention. And everything is about trying to understand the mechanism of why is he vomiting so much blood? Why is he confused? But if you're not careful, the subtlety of his presentation is absolutely critical to understand. And what I see is that if you're not careful and you don't look for the signals before becoming unwell, the presentation will make no sense. Now, look carefully at this history. Now, remember, I'm just reading the newspaper report. I haven't seen the patient, but I can pick up the nuggets from the newspaper report about what is likely to be relevant. So follow here. So he was critically ill at the time, except in recent weeks, his breathing had become labored. Now, you have to get attention here, because what this indicates is that he was unwell for a few weeks before this happened. So when she looked at the case, his breathing, so getting up the stairs to the bedroom in his home, this is in New Zealand, he had become noticeably harder to do it, and occasionally he had been coughing up blood. Now, this is an absolute red flag in terms of the shortness of breath, coughing up blood. Once you hear that, you automatically would go towards a pulmonary embolus. And it makes perfect sense. And in the context of him having all of these clots, this made perfect sense. Now, again, the simplistic approach will mean that you focus on the fact that he just happens to have a pulmonary embolus. You treat that, he's okay. As long as he doesn't die from the clot blocking the arteries going to the lungs, things should be fine. But it's not so straightforward in this case. So his wife knew something wasn't right. As she says here, instinctively, his wife's gut feeling told her something wasn't right. Now, this is a critical information, but Jen initially reasoned it was to be expected, considering she had not long been in hospital after contracting influenza B, which also caused her to cough up blood. Now, this is really important because influenza, whilst it can cause relatively serious pneumonia, especially in older people, sometimes in younger people, you can get a viral pneumonia. It doesn't cause the constellation of symptoms that Ruben had. Now, here is where my thinking is a little different. Once I hear about a viral infection, what can be seen very often is what I call a co-infection or a prodrome to the influenza or RSV infection, viral infection, and that's COVID. Now, a lot of people don't get the relevance of this. So let me try and see if I can simplify the concept for you. COVID can present as a very mild infection. Now, the problem is that it suppresses the immune system. It shuts down interferon responses that are usually the alarm bell for the immune system. When it shuts this down, the individual becomes more prone to other viral infections and some bacterial and some fungal infections. If you don't look carefully for the transition in the weeks before, and usually is very subtle, mild infection in terms of not even upper respiratory symptoms. Oftentimes, people just have a headache and a bit of fatigue. That's it. But they knew they weren't right. Sometimes they do a test, it's negative. They're looking for COVID. So therefore, when it's negative, they perceive that they haven't had COVID. And in this case, when you then follow it on with influenza, the logical assumption is that this was just an influenza infection, except that this is not usually how influenza presents. Not that it can't. So the doctors at Christ Church Hospital thought he had a viral pneumonia, makes sense, which caused him to end up on a ventilator twice. So it means he went into intensive care, he was taken off the ventilator, deteriorated, went back. Now, thought he had a viral pneumonia suggests it wasn't obvious. And this is where the problem comes in, because the clinical presentation may look like a pneumonia, but when you look at the imaging, it's not so clear cut. Why is the patient still on needing a ventilator unless they have got severe pneumonia? It doesn't quite add up. How then also do you explain the vomiting of the blood? And influenza, oftentimes, if you're going to get sick like that, usually in a young, fit, healthy person, doesn't normally do that kind of presentation. Okay? Now, here is where it gets really complicated. When you look, what doctors did find was hundreds of blood clots littered throughout his body and a dead lower lung that he'd been coughing up. So remember I mentioned the pulmonary embolus. He had got multiple emboli scattered throughout his body. One part of the lung had collapsed. This is why he was probably short of breath, as well as the pulmonary emboli. So the whole picture doesn't add up. I mean, you can get a pulmonary embolus after you've had a viral infection, including influenza. But the coughing up blood suggests the pulmonary emboli, which was some weeks before. This is why he was short of breath. But then when you go further, and this is why I'm saying, when we talk about how COVID presents, it is a beast of an infection when it does the damage that can happen. Look here. I remember I asked how many blood clots, Jen recalled, like 10 over his body. And they said, no, they're everywhere. We don't know what's going on. We don't know what to do because he will bleed. He had come in bleeding. He's got clots everywhere. And now he has kidney failure. Lungs are shutting down. And his heart was shutting down. On top of that, a series of mini strokes as his body shut down. I'm just saying. Somebody could say, yeah, well, that could be influenza. Yeah, it could be influenza. But if you told me COVID, that would make perfect sense because of the clotting that occurs. They are stuck in this situation. And as you can see here, they mentioned of immediate concern where the blood clots is unable to take blood thinners for the blood clots because it would make him bleed more because he had come in with vomiting blood. So they put in a filter to try and manage this. Now, here is the final bit that makes you know this is really strange. So the doctors, the cardiac and respiratory doctors, are battling over what was more critical, his lungs or his heart. He wasn't even conscious at that stage. But what you have to look at carefully is where this has gone. And now follow along. Here, in and out of hospital, his deterioration was sudden and heartbreaking for both of them. And they don't know if he'll survive another day, let alone the time it takes to assess if he should get a heart transplant. Now listen, a heart transplant in the middle of all of that. So you have got multiple organ failure. So let me just go through the history. The history is a fit and healthy 50-year-old going to the gym twice a week, actively doing judo. His wife recently got a viral infection, influenza B, and ended up in hospital with a pneumonia. She was okay. However, he then started to have labored breathing for a few weeks. He had a cough for which he was coughing up blood. Then he collapsed and was vomiting blood. When they took him into hospital, he needed to go on intensive care. He was put on the ventilator, taken off, had to be put back on it. When they did the scans, they found clots everywhere through his lungs. He had multiple mini strokes. So remember, unless he has a hole in his heart, it means that he is making clots on both his venous system and his arterial system. He has gotten kidney failure and he now has heart failure. As far as I'm concerned, this is not influenza. It's possible. But if you told me he had a positive COVID swab, it would make perfect sense. The problem is that his time from symptom onset to admission to hospital was weeks. If you do a COVID swab at that time, of course it will be negative. But the immune manifestations, those kick in long after the viral infection has gone. This is the bit people don't get. COVID is primarily a vascular immune disease. It damages the lining of the blood vessels. It triggers clotting. It causes all kinds of inflammatory processes because if he needs a heart transplant, the likelihood is that they have already done an angiogram to make sure that he doesn't have blockages of the blood vessels. The likelihood is that his arteries were clear because if they weren't, they would have opened them up. So it means he has heart failure in the context of no obvious ischemic heart disease. Now I'm extrapolating because I don't have the details, but that sounds like the likelihood, which then points to a likely myocarditis. This is why I said when you pull back from it, the thing that makes the most sense is what I describe as the COVID storm. And I did this presentation a while ago. And just to give you context as to the immune mechanisms I'm talking about, this spike protein can bind to multiple proteins. The most significant one, ACE2, is what it uses to enter, but it can then trigger immune responses targeting ACE2, including furin, neuropilin 1, DC-SINE, the platelet activating factor 4. All of these things then can cause a multitude of symptoms. And when you look at the autoantibody response in severe COVID, it literally, interleukin 4, interleukin 17, interferon, gamma, GM-CSF, interleukin 6, interleukin 3, autoantibodies across a broad spectrum of disease. And this is in severe COVID. The problem is patients are not presenting as severe long COVID anymore. And so nobody is making the connection. And based on this, because this was what I called the storm presentation, I anticipated you'd have viral dissemination throughout the body. This would then lead to the lung storm, clotting, microclotting, and clotting. It would lead to, this is the inflamed lung, brainstorm, inflammation. This is what causes confusion, as well, neurological symptoms. You would then have the heart storm, type 2 hypersensitivity, leading to myocarditis, global heart decreased heart contractility, heart failure, kidney storm, intestinal storm, colitis, potentially contributing to the upper GI bleed, vascular storm, blood clots on both sides, venous and arterial clots. I put this together as part of my advanced COVID-19 course because I had to capture these ideas. I just don't know how long it will take for this kind of presentation to become the normal. And this is why these cases are so very important for us to look at. What could they do? This is my final thought. If you are advocating, it's very difficult to advocate for COVID when they haven't got a positive test, because very few people will consider the history or the clinical presentation as the diagnosis without lab confirmation. I think that's a mistake. I think this should be a clinical diagnosis, meaning it should be COVID until you prove otherwise. If you have no other cause, assume it's COVID. So within that framework, what you expect in a COVID storm is that this is being driven by a cytokine storm. It's still autoimmune inflammation causing the myocarditis, causing the clotting, causing the nephritis, damaging the kidneys. Everything is immune. And so therefore, what you would have to advocate for is, should they consider immune suppression as the primary mechanism to manage these patients? If that family is listening, I don't know if they are, that's what I'd suggest. If they haven't yet tried immune suppression, if they haven't yet brought in the rheumatologists to say, could this be? Should we do a trial with high-dose steroids or whatever to see if that can impact the presentation of the disease? Because where they are now, what have they got to lose? Because if it is inflammatory and it is persistent, even replacing the heart will not guarantee that that process will not continue and damage the same heart that has been given. This is what we're up against. And at the moment, very few people are considering this kind of pattern of thinking. Somehow, and I'm using you as part of my educational tool, hopefully maybe some clinicians are watching this as well. They can take this information. It doesn't mean people have to do it, but you have got to put it in the differential. Force them to exclude it from a logical point of view. You can almost bet this guy's inflammatory markers are persistently elevated. And so that's the picture that we're facing. And based on the fact that COVID continues to circulate, especially in highly vaccinated regions, all I can say is the likelihood is that this will continue to rise. This is what we will see. One after the other, not making sense, overlapping each other, everything happening. It is a nightmare of a situation. And so it's very sad. And I will leave you at the end with regards to what he was saying at the time in terms of his own view of mortality, what will happen to his family. We have got to find better outcomes. Whatever it takes, we've got to do better. Let's listen to him at the end here.
What's been the hardest thing for you about all of this at the moment, Ruben? Is it being immobile? Is it, you're facing mortality? Talk to me about what has been the hardest thing.
It's everyone else. Everyone around me. I've already come to terms with, had a lot of time to think about myself and that aspect, but it's what I leave behind, particularly a 12-year-old daughter. It's kind of that 12, 13, it's a very important part of most young adults' lives, and she'll be going through a lot of emotions. And she'll be going through that, even if I wasn't going through this, I had that on. And then just, I guess, what's going to happen. I worry about what I'm leaving behind.
Worry about him. I can't sleep because something was to happen. Yeah. Same with leaving every day, I'm busy.
What's been helpful in getting you into that process of trying to come to acceptance with your health?
We got no option. It's that simple. Mm-hmm. There's no amount of anything. So, you'd sit there, and I'd sit there, lotto, $40 million, and you dream away what you'd do. Doesn't matter. I tell everyone it doesn't matter. The only thing I can say is that I'm okay. The only piece of advice that I have for people who are not maybe facing the same thing as I am is at least stop and breathe. I know it's so cliche, but just stop, breathe, and just have a look around and just be thankful. Just like it's so cliche, but it is. We take for granted a lot of stuff. Mine was, I don't know what's going to happen, but I'm okay with that.
It's extraordinary.
It'll be what it'll be.
Yeah. Tough to see. At this stage, he is 4 months down the line. So even if there was an inflammatory component, the damage may have been done, and maybe all that he can get is a heart transplant and hope that inflammatory process is not still continuing. All I can leave you with is that these days your responsibility is to understand as much as you can so that you can advocate. You can ask the clinicians the harder questions. You can force them to think outside the box. Because if you are in that situation, or a loved one, the earlier that you intervene, the better the chances that you have for reducing longer term damage. We can only wish Ruben all the best and hope that this understanding can benefit many more people in the weeks, months, and years to come. Thank you.
A hero, an immune adventure, Humming Heroes, your lyrical guide to the body's defenders. Now on Amazon. Check the links below.